Thank you, sir.
Okay, sure. Okay, so again, in our learning phase about the cost report and what we can learn from it. So here mostly just to hear your response to some of these measures, but for a small rural hospital, we see Northwest right at the median. So again, 50% of the hospitals in the comparator group were smaller and 50% were, or half were larger. And for your case mix index, we see a relatively lower acuity, very similar to your peer in Southwestern at 1.39. I was just curious if I've heard other hospitals say that, you know, really getting full credit for your CMI usually depends on some expensive software and other tools. So I was just wondering if you feel like there's any distortions in that CMI compared to your peers, and if you had to guess.
I think that number might be a little bit soft, what Stephanie said earlier, with our new partnership with Dartmouth and tele-ICU. So we're keeping higher acuity patients. So some of that may be just the timing of that data. Stephanie, I don't know if you want to chime in on that.
Yeah, I mean, it's every, CFOs love this stuff, right? Like, how do we make sure we get paid for everything that we do, right? And get credit for everything that we do. And so, we've really looked at something called CDI, Clinical Documentation Integrity, and have one of our staff members actually going through a CDI certificate program and education so that she will be reviewing in real time, the inpatients on the floor, looking for anything that might be missing around coding or documentation, just to try to make sure that we get this right. Because I completely agree with Southwestern. It's a tricky thing. And you miss stuff, and sometimes you don't know what you don't know, right? You don't know what was missed. And so that's, I would just say ditto to Southwestern.
Okay, fair. And then when it comes, I think this is the indicator we're struggling the most with, and maybe it's going to be one of them that we need the most work to make sure we're measuring what we intend to. But we do see your, so again, this is the ratio of what's classified as true admin in general on line 5 compared to the salaries listed through lines 30 to 100. So it'd only be the labor that actually shows up on your cost report, which I know often doesn't represent everything. So I was just wondering from where you sit, like what we might be missing from looking at it this way.
Yeah, this was one where I really thought about it over the weekend and thought, man, I don't have a great answer to it, knowing that we're showing a bit on the high side. But, I will say I'm really curious. It's one of the things I'm going to dig into right after this budget process and try to understand if I'm doing something differently on the cost report than my peers are. So no specific comments at the moment. I won't call it wrong. I won't call it any of those things. But it's just something that we're really going to dig into.
I appreciate that. And, we are toying with kind of more representative ways to get at like a apples to apples admin ratio. So appreciate your wisdom on that. From what I understand, that line 5 doesn't have a whole lot of guidance. And so all sorts of things may or may not end up there. Okay,
choice.
Thank you. Yeah. So this would be the cash available for operations at the end of fiscal year 22. Given your submission, I think your cash position probably looks a bit different today. And I also know that this would not account for any donor restricted funds. So I just want to give you an opportunity to comment on anything you think might be non-representative about that particular measure compared to your peers.
Yeah, I mean, we've always been fortunate. I won't say always, but in the recent history have been fortunate to maintain our strong days cash on hand. It's really helped us get through the last 5 years, right? And we absolutely were using that money right now to fund, an ED renovation project that's really needed, and we're very excited about that you all approved a couple years ago. So, we continue to look at that money as a way for us to really move the organization forward in the future at a lower cost to the system, if not having to borrow.
Yeah, I think that's important that we fully fund depreciation. And so our capital costs each year are cash, and we're not taking on debt. And that allows us to maintain a really strong structure of low cost.
Yeah. And then, like I said, the profitability measures, I don't think are where anyone would like to see them in fiscal year 22. So obviously that came in negative, but around the 25th percentile, so even kind of relatively worse operating results than some of your companions here. So seems like things are starting to turn around in fiscal year 23, but still a long way to go. Does that feel representative?
That is correct.
Yeah, it's my least favorite statistic, Sarah. And the one that keeps me up at night is our current operational deficit. And, we're going to have to make some very complicated decisions to get back in a safe and responsible level.
Yeah. And so when we look at the average cost for a Medicare discharge, so from what I understand, this 13,000, if say your CMI was a little bit up, would probably drop down into this box is kind of what I'm picking up. But I just thought what your reactions were to seeing that compared to some of these other hospitals.
Yeah, it's the first time I've seen it CMI adjusted. So if I do just the traditional, right, cost per adjusted Medicare discharge, I get like $9,500. So seeing this CMI adjusted number, it's kind of like, oh, is that correct? Is it that sensitive to the adjustment of the case mix index? And that's just something that it's also something I'm really going to dig into after these budget hearings, because I think that's the only difference between the way I've always traditionally calculated it and the way it's being done here. So just something for us to dig into, but happy to dig into it.
Sure.
Nope, I've already been in it once because I didn't see Teams meeting in Outlook.
Let's see, somebody. Oh. Okay, I think we're good there. Okay, and then so cost coverage, when I look at Northwest, for one, I see not having cost covered on the inpatient side from commercial, and that kind of stagnating. Looks like there was a little bit of a bump maybe. Again, this is sensitive to the data we have access to, but kind of been stable through 21 and 22. See kind of a general deterioration in the inpatient coverage for Medicare for you all, and low, but more consistent outpatient coverage. And again, seeing a similar downward slope for the Medicaid. And when I look at you compared to your peers, you do show up as being one of the lower cost ones. And it does look, I just look at the outpatient, you are notably one of the lowest, with the coverage being about 261% of that Medicare allowable cost, but
Sarah?
on the inpatient side, yeah.
Sarah, I think that's North Country. I believe we were under the PPS hospital NMC.
Of course you would be. Thank you. I was wondering why this didn't make sense. Okay, there we go. Thank you very much. Yeah, so there you are. Yeah, very in line with your peers, but that cost coverage quite low for inpatient, but for both governmental payers, and also not keeping up with commercial, as we saw. And thank you for that correction, because that's a totally different story. And we see, yeah, you're at just under 200% of the Medicare allowable cost, but not meeting those costs for either governmental payers. So just seeing that your relative payment, though, is quite low, you and CVMC being the lowest. And that seems to tie to, if I were to reverse engineer some of the things in your narrative, you saying that your charges are among the lowest in the state. And so my main question here just has to do with, it's always a tough decision about figuring out what you need to ask from the commercial payers, and just curious how you approach that task and how you're dealing with it in this recovery period.
Yeah, I think, as you can see, this kind of really highlights the cost shift effect. What we ask for commercial, we always try to go in with as low a rate request as possible to try to be reasonable, just to keep, operations going. I think that, we've got to have some very real conversations about the cost of inpatient care and the shift back. We saw a dramatic drop in utilization during the pandemic, and those patients are sicker, and they're coming, in a regular stream, and that's not just Vermont. I saw it in Maine. I saw it in New Hampshire, and with the connections I have across the country, we're seeing the same thing. So we've got to think about this. This goes back to rate reductions that from about 8 years ago. There was a pretty significant rate reduction. And we've paid for that in the 8 years since with operational losses. So we've got to find a way to get that back to at least that dotted line, but do so in a reasonable way. I mean, things are changing, and and payment reform is real and something that we not only subscribe to, but we're an advocate for. So we're trying to figure that out. And I wouldn't say that we actually have an answer for it today.
Right. You'd be too busy collecting your Nobel Prize if you knew that.
Right.
And so as far as the RAND data goes, I think this is where I noticed it's most material, the lower than typical commercial reimbursement. So Northwest is below the 25th percentile on inpatient at that 14,000. So what we do is we figure out how much was paid for commercial and divide that by a standard unit of service. So compared to your peers, you're quite low on both inpatient and outpatient side. So below the 25th percentile and right at the 25th percentile. And I think, again, that jives with what was in your submission. So those were the things that to cover in this tool. I don't know if there are questions from the board or the healthcare advocate that would be helpful to have this up for, but I would welcome those now.
Sarah, can I just ask a quick question on this, which is, can you or Stephanie or Peter understand how to reconcile that CMI adjusted cost per Medicare discharge, which is high, and the RAND cost per inpatient stay? They're at the opposite ends. Most of the trends in what I'm seeing is that their reimbursements are low, but I'm not quite understanding how the cost per discharge is high with the reimbursements being low in other places.
That is definitely a Stephanie question.
And it's definitely one I don't have the answer to today, but yes, we can, right after this, really dig into that. And because that's just when I go through all of our data on this tool, that CMI adjusted cost per adjusted discharge number is just the one that I was like, oh, that just really doesn't look right. It doesn't make sense. So yes, we're just going to have to figure that out.
I will just point out that this specifically is going to be limited to the commercial side of it. So it's entirely possible to have a high cost per discharge, but not get reimbursed well from a commercial payer.
That is true.
If that helps. Or, well, I mean, I don't mean to have a judgment there, relatively lower than your peers. Sam, you came off camera. What do you got?
Thanks, Sarah. I don't know if this is the best place for it, but I think it makes sense. Sam Peisch, healthcare advocate. Good to see everyone. Just want to start off with a couple brief comments. I really want to commend Northwestern for the work that you've done coming in really close to the guidance. I think last year, if my memory serves, you were the only hospital that came aligned with the guidance. And also your strategic investments in labor and reducing operational expenses at the same time. I think sometimes we hear that those two things can't go together. But I think it's a testament to the culture that you spoke about. I wanted to mention with the implementation of Act 119, the Patient Financial Assistance Bill, we hope that we can work together as we did years ago, and a kind of interactive process to that we hope to do with all hospitals, but we have that existing relationship, so we hope to build on that. So our question is, I mean, no surprise related to free care and bad debt. We noticed a trend towards more uncompensated care overall and also more bad debt in the last couple of years. I'm just wondering if you could speak to that and elaborate on why that's the case.
Sure, I'll let Stephanie provide the detail, but I think we're pretty consistent with what we heard other hospitals testify. We'd love to see that shift. We'd love it if patients would fill out that paperwork. And our encouragement. You'll notice in our budget submission that we provide access to financial counselors and have a very robust charity care program, upwards of 400% of the federal poverty level. So there's a lot of opportunity. we would certainly love to see that shift. It's really about patient engagement and patient participation that we're just not seeing a response, and patients taking that seriously, which is painful for us as well. Stephanie, you want to fill in some more detail?
Yeah, I mean, I think you're right. We're seeing both buckets increase, and we want to see the charity care increase above seeing the bad debt increase, right? And everybody, I really don't think this has an impact to our bottom line. I really think if we can get more charity care, it's really just going to come from that bad debt line and have a zero, effect on our P&L. So we would absolutely love to see that. But right now we're seeing increases in both, and increases in both does have a bit of an impact to your overall bottom line and profitability. And so I think, I don't have a great answer other than to say, I really do think that some people personally haven't financially recovered from COVID, right? Whether there was a loss of employment or whatever the case may be. I really think that we are seeing folks have not really recovered personally from the last few years, and that's really showing up. And so they probably deferred that healthcare for a long time and can't defer it anymore. And now they're receiving that healthcare and they really truly don't have the means and the resources. So we're just trying to strike the right balance as an organization between, providing the resources to get them pointed in the right place, to get them help. We've got our staff not only doing the financial counseling, but they're also those trained, certified on the exchange, whatever that title is. You guys know what I'm talking about. They're trained in helping folks get those Medicaid applications done and getting health insurance through the exchange. So what else can we do to provide support? Because I think what we're seeing really is just a bit of a lag in the day-to-day struggle of some of the folks in Vermont.
Navigators.
Navigator, certified health insurance navigator or something like that. You're right.
Yeah, no worries. Does that cover you, Mr. Peisch? Anything else you wanted to ask? Looks like maybe we're having a little technical difficulty.
There's Eric.
Eric, you're on mute.
Technical difficulties. He just froze. But that is all our questions. I mean, I think just one comment is for Stephanie. I think, our office is interested in the kind of figuring out the underlying processes and the path towards free care. And so I kind of have a gut reaction to it's a patient. Right? I mean, I think it is partially, but if I have a $5,000 bill or a $1,000 bill, the kind of underlying premise of that is I don't care. And so I think, most people care, and most people care about a quarter of their monthly salary, right? I just don't find it plausible, but I am interested, and I think this will partially aligns with lean thinking, is how do we optimize the processes and the pathways that cause that? And I think that's been a consistent process that we've been interested in. And I think Rutland has done a really good job of, or their staff members done a good job of looking at that. So I think that is something we'd like to address. Your ratio is honestly, it's one of the worst in the state. And I think we see that trending towards being worse and worse and worse after you reach the high point, I think in 2021. So I think that is a process that we could look at and should look at, because it's trending in the wrong direction. But again, I want to echo Sam's statement, is we really appreciate how close you've come to the guidance this year. And it is, I think, worth pointing out that you guys were the sole Vermont hospital that came at guidance last year, if my memory serves. Thank you.
Yeah, I
Thank you.
completely agree with you. And I think, when we talk about, can we get these patients to engage with us more? I couldn't agree with you more. People are going to fill out a piece of paper if that piece of paper is worth thousands of dollars to them. And so I think where we do a bad job explaining it is what we really mean is we think that we are advertising it well with like signage and what's on the website and with the counselor at the front of the house, but still somehow the message to the patients isn't getting delivered, because I do agree with you. If they knew about it, they would do it. And so if there's someone, you folks, Rutland, that we can talk to and work with about, how did you change the level of awareness to actually change the results? That's the piece where I just feel stuck and would love to collaborate with folks.
Let
Yeah,
me
and I think
reach out.
sorry,
Go
go ahead.
ahead, Mr. Wright. I was just going to
gonna-
say, sorry. We both said go ahead. I would agree with that. And I mean, I think it's we don't know the answer, obviously, to how do you create a system that works, and it's exceedingly complicated. And I kind of think it's, somewhat of a trial and error, but I am interested in, I think the knowledge share, and how that occurs in Vermont is something that you guys are working on, and I think has been a long-standing wish of mine or hope. And I think, to the extent that we can facilitate it around free care, we'd love to. And I'll write down a note and reach out and see what we can do, Stephanie.
Yeah, that's what I was going to say. This is a great high reliability lean daily management project for us. It's obviously an area where we're not strong. And if we haven't been able to figure out through our own internal improvement process, then we are more than wide open to learning from others. I think it's something that, Vermont hospitals do really well is share best practices. But I agree with you. I'm not sure that while Rutland may be doing it better, I'm not sure we do it well as a system anywhere yet. And so, but anything we can do to improve the numbers, we're certainly up for.
Will do.
All right. Sorry about your technical difficulty there, Mr. Peisch. Any other questions you'd like to ask?
Yeah, sorry about that. It was not my intention to ask a question and then ghost. My computer just shut down. I apologize. I just wanted to, I don't know if this will be covered by the board, but I heard, I believe correctly, that Northwestern, you wanted to talk in executive session on Medicare Advantage plans, and I had a couple of questions related to that. So I wasn't sure if there was a process for that, but just wanted to bring that up again.
No, we didn't have necessarily a desire to proactively talk about that, but I know that the board has had some questions. And so if the board has questions in that realm, we would just ask to go into executive session.
Nothing else from us then. Thank you.
Before we maybe entertain that eventuality, just making sure we're all ticked and tied here. The final rule had 0.3% increase for Medicare IPS between the prospective and final. Just wondering if that had any material effect to your budget.
Yeah, so for us, that's worth just a little over $100,000. So not material, but I understand that that's real money. I would say what has me very worried on the other side of the coin is the Medicaid redeterminations. And that question's probably coming next, so I can wait if you don't want me to go there, Sarah.
Perfect segue. Have at it.
Okay. Okay. So we did not budget anything specifically for those Medicaid redeterminations. Again, not knowing like those patients are going to go somewhere. Are they going to go on some sort of a commercial plan and it will actually be better? Are they going to be true self-pay? Are they, not knowing? It just felt like we couldn't take an educated guess. And if I can't take an educated guess, I don't want to put it in the budget. So I think that there's a little bit of money there on the Medicare side, but I'm really worried about the potential of the Medicaid side.
Understandable. Okay. I think that covers all the staff questions. We think we've heard from the advocate. Any other board questions or further business related to this hearing?
I may have missed it in the submission, and so my apologies, but could you speak a little bit about ACO participation in the coming year?
Yeah, the ACO, so we've budgeted to be a participant in the ACO. In this budget, when we put it together a couple of months ago, there are some things that have changed, to be honest, since then. And so we're in a dialogue with the ACO right now and our board of directors about the fate of our participation. So in all good consciousness, I can't tell you one way or the other, but it is part of the budget.
Any other board member questions or comments for Northwestern? Okay, I may have a question on the MA issues, but first I'll take any public comment via the raise your hand function. Okay, seeing none. So, Mr. Wright, I'm not sure how familiar you and your team are with this process, but I need to ask some questions first before we can go into executive session. I would have to make a motion. And so I need to ask you, what I'm going to ask you about is some of the details relating to the payer shift to MA and some of the impacts that that's having on your business and some of the negotiations and work you're doing with the MAs around the Medicare Advantage plans around those issues. So the first question I have is whether or not you believe those questions, the answers to those questions would, the premature general public knowledge of those issues would cause you a substantial disadvantage with respect to your negotiations.
Thank you, Chair Foster. We do believe that would have a negative impact us and would request a more appropriate venue to discuss them.
Okay. Okay.
Oh, and before you make the next motion, there's another topic that I think potentially could be added to executive session, which is I think having more detailed information about the contract negotiations with the ACO program would be helpful information to have. So I will ask you, Mr. Wright, if having premature general public knowledge of those negotiations might negatively impact Northwestern's ability in that negotiation.
I believe it would, Ms. Lunch.
Thank you.
Okay.
Back to you, Owen.
Sure. No, thank you. So I'll move that we find that premature general public knowledge of Northwestern's negotiations and work with Medicare Advantage plans and negotiations with the ACO would put Northwestern at a substantial disadvantage with respect to its negotiations with the ACO and Medicare Advantage plans.
I second that motion.
All those in favor, please say aye.
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 The motion carries unanimously. Aye. The next motion I would make is that we move into executive session under 1 VSA 313A1 to consider Northwestern Medical Center's negotiations with Medicare Advantage plans and also with the ACO.
Second.
All those in favor?
Aye.
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 Aye. So the motion carries unanimously. And we'll take, I'll turn to Ms. McCracken really briefly, but before I do that, we'll take a 5-minute break after Ms. McCracken finishes to switch over to the executive session. You should have a link. And Cassidy, I think you have it as well. Is that right? Great.
I do. Thank you.
Okay, we'll just give you a couple minutes to set up because I know it takes a little transition.
How do we get that link?
So
Where
Mr.
would that be
McCracken?
put?
In your email.
In my email.
Just came
Okay, thank
through.
you.
Thanks,
All right,
Chair
talk
Foster.
soon.
I was just going to confirm the attendance for the executive session will be board members, staff, hospital budget staff, board legal, the Northwestern Medical Center team as you think is appropriate. Um, um, the healthcare advocate, Mr. Peisch or Mr. Schulteis or anyone else from your office, and Cassidy, our court reporter. Does that sound right? Did I forget anyone? All right. Great. Thank you.
Okay, great. So we will adjourn this session. And for those who are not going to the executive session, I am going to estimate that it'll take 20 to 30 minutes in the executive session. And we'll be over there and we'll start that in about 5 minutes. So 11:38, 11:39, we'll start the executive session. And we can adjourn this for the time being. Thank you.
Hey, long time no see, everybody. Now my computer wants to work.
It looks like we're just waiting for Cassidy. It takes her a moment to switch everything over, so we'll just give it a minute.
Thank you, Chair Foster. I'm all set, and thank you all for that consideration.
Great, thank you. Okay, we will resume the hospital budget hearing on Northwestern Medical Center. I think we have gone through all board member questions, public comment, HCA, and we did closings. So I think we are all set. Is that correct? Am I missing anything?
I'm not sure we quite gave an opportunity for a closing remark, so we can probably do that and call it a meeting.
I'm sorry. Then we will do so. Mr. Wright, please go ahead.
Yeah, I just want to thank everybody for your time, your encouragement, and the great questions that you asked. Like other hospitals, it's a challenging environment, but we're very proud of the budget that we put forward. We feel it's responsible. We came close to the guidance as best we could while maintaining what we hope is our fiduciary responsibility to our organization and community, and keeping our patients and our staff at the forefront of everything that we do. So thank you very much for your service. We appreciate this time to talk to you about our budget today, and look forward to any follow-up questions that you may have.
Oh, great. Well, thank you very much, Stephanie, Mr. Wright, and Mr. Batchelder. Is it Briel? Is that how you pronounce your last name? Briel?
Lots
Bro.
of unnecessary letters. It's just bro.
Bro. Great. Well, thank you, Miss Bro. So we will adjourn at this time, and I actually need a full hour before the Rutland hearing. So we will start at 1:20, if you think that's okay, Sarah?
Yeah, I know we have a hard stop, so we'll be efficient.
Okay, why don't we do, we'll do 1:15 then. Okay, we'll see everyone at 1:15. Thanks.
Thank you, everybody.
Thank you.
Miss Barrett, if it's no trouble, could I ask, when they introduce themselves in the conference room, if they also spell their name for me? I get a lot of advantage from the people, having their names on the screen. So I appreciate your consideration. Thank you.
Sure. Judy Fox, I don't know if you heard that when you all introduce yourselves, if you could spell your name as well for the court reporter.
Yes, we can do that.
Thank you very much.
Thank you.
Do we know why that's cockeyed like that? Is that better angle?
Technical thing.
Official.
That was the first 30 minutes of the dress rehearsal. Manufacturer guidelines there.
Can I read my paper?
And that was Jonathan.
All right, just so you guys know, you got a little bit of a hot mic. I mean, keep talking if you want, but just to let you know, everyone can participate. Okay, do we have Cassidy? Yes. Sarah Lindbergh, are you here?
Yeah.
Great. Okay, so I will call our meeting back into order for August 14th. And we are going to hear from Rutland next. And what we'll do is Mr. McCracken will swear in the Rutland witnesses. And then Ms. Fox, I'll turn it to you for you and your team to introduce yourselves and provide an opening statement to the board. And before you get started, thank you all for being here. And Ms. Fox, congratulations on your new position. So happy to hear from you.
Thank you.
Good afternoon, Ms. Fox and the Rutland team. If you could let us know who is going to be presenting and answering questions, and if you wouldn't mind also spelling your name when you introduce yourself, that would be very helpful.
Can I start with me? Yeah. My name is Elizabeth Kyhill. Elizabeth, traditional spelling, and then Kyhill, Kyhill.
Good afternoon, Jonathan Reynolds, Vice President Clinical Operations here, JONATHANREYNOLDS.
And Judy Fox, President and CEO, and it's Judy with an I, JUDIFOX.
Mark Foley, Chair of the Board of Directors. It's MARKFOLEY.
Kelly Watson, Chief Nursing Officer, and it's KELLYWATSON.
Thank you all very much. If you'll raise your right hand, I'll swear you in. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
Great. Thanks very much, and I will turn it over to you.
So thank you. I'd like to start by thanking Chair Foster and all the members of the Green Mountain Care Board for the opportunity for us to support the Rutland community by allowing us to highlight information that we feel is informative and relevant and important to the decision that you, the board, has before them. I'd also like to thank Director Lindbergh, who has been a consistent and transparent partner to Rutland Regional as we've moved through all aspects of this budget. We have found Director Lindbergh's questions to be both inquisitive and helpful, and we'd like to acknowledge her in her work in providing a benchmarking tool that is consistent among hospitals. I won't introduce the team again. We have introduced ourselves. You'll hear from each one of us. In addition to the team that will provide testimony, we are also joined by hospital leaders, by physicians and board members who are all here in support of our community and our budget. But I first want to ask our board chair, Mark Foley Jr., to provide a few opening comments.
Thank you, Judy. Good afternoon, Chair Foster and members of the Green Mountain Care Board. So much has happened since you visited Rutland Regional last December. Most significantly, as Judy noted, the board named her as permanent CEO in June. Judy's exceptional leadership and organizational credibility has made an immediate impact on Rutland Regional. I want to thank you for the opportunity to provide comments on behalf of Rutland Regional. I've had the privilege and honor to serve on the hospital's board of directors for nearly 8 years, spending the last 18 months as board chair. As a native of Rutland and a fourth-generation business owner, this community and this state are especially important to me and my family. Rutland is where I grew up. It's where I raised my family, developed my business, and where I focused much of my volunteer service. Rutland is a special place with much to be proud of, and like many rural communities, it faces ongoing challenges. Rutland is an aging community. We are impacted by increased substance misuse and addiction. We struggle with increased mental health issues, and like communities across the state, we struggle with housing and workforce shortages. More and more, our community relies on Rutland Regional Medical Center, our local healthcare providers and human service agencies for support in a variety of essential services. As a longtime resident of this community, I want to ensure that Rutland is a vibrant and strong one with a thriving economy and healthy population who can experience all that the region has to offer. This requires a strong community hospital. As one of the region's largest employers, the hospital plays a significant role in the strength of our local economy. It is a relied upon leader and partner in the community, collaborating for the greater good, supporting economic development and revitalization efforts, and helping to further the mission of local nonprofit organizations aimed at improving the health and wellness of our Rutland County region. For more than 25 years, the hospital has led a community health needs assessment, identifying health improvement priorities and supporting projects that address the health needs of residents in the Rutland region. The hospital has worked closely with community partners, coalitions, and organizations to address the identified health priority areas outlined in the 2021 health assessment, including housing, mental health, child care and parenting, and supporting an aging community. In support of those health needs of our community, Rutland Regional's James T. Bowes Health Trust has been awarding and managing grants in the Rutland region since 1997. Since its inception, the Bowes Trust has awarded more than $4 million to programs aimed at improving the health status of residents throughout our region. Because of these efforts and more, Rutland Region is a trusted and relied upon partner in our community. 2022 was a difficult year. And while we needed to raise rates, we have also taken a diligent approach to lowering costs. The hospital has done considerable and effective work over the past number of months to reduce costs, address culture, workforce, and safety issues. We are focused on keeping high quality care in our community by investing in physicians, nurses, staff, and equipment that support community needs with timely access to care right here in our region. As a board, we realize that our workforce is our most important resource. Our community relies on our dedicated healthcare leaders, providers, and staff in so many ways. Attracting and retaining experienced providers and staff to live and work in our region is critical to our ability to provide high-quality healthcare to our community. It's also important to understand that Rutland Regional is just one of the many healthcare organizations in our community. We value our strong collaboration with our partners, and we are committed to our continued work with primary care, mental health, home health, and other Vermont hospitals to provide care in the right place by the right provider and at the right time. Thank you for the opportunity to be here this afternoon. At this time, I'd like to invite Judy Fox to share some of the details of our 2024 budget. Judy?
So like other hospitals in Vermont, all of whom you've heard from, Rutland Regional has faced significant challenges in trying to strike the right balance in providing high quality access to care while addressing our cost structure and acknowledging concerns of affordability. As Mark had said, 2022 was a very difficult year. We lost $12 million from operations, and when you layer on our investment losses, that amasses $41 million of loss. As a result, we were in breach of debt covenants, risking a bank call of $43 million of debt. We were able to agree on a covenant suspension but unfortunately the process was costly, and it also required that we increase our liquidity position to be increased until we could demonstrate ongoing compliance, and so that was difficult. The breach also weakened our ability and capacity to consider additional debt, while we are also at the same time trying to come out of COVID and support our mission and vision. While our loss was significant, in many ways, we need you to know it was also deliberate. We have faced and continue to face staffing shortages, both within nursing and direct care providers, and also with our own physicians. To date, we have 176 open positions, and we're also recruiting for 12 full-time positions. Regardless, we made the decision not to limit access to care. Instead, RRMC remained committed to reinforcing our workforce through use of temporary staff and our locum physicians. This was costly. In 2022, it drove additional costs of nearly $24 million. In 2023, we expect about $21 million of additional cost. And in 2024, while we've made some impact, it's still $18 million. Elizabeth Cahill will share how RRMC maintains our strategy to deliver value-based care in our own community despite these staffing shortages.
Thanks, Judy. Good afternoon. Again, I'm Elizabeth Cahill, and I'm the Vice President of Medical Group Operations at Rutland Regional Medical Center. So at Rutland, we take the strategy to ensure access to value-based care seriously, as it requires that we care for 60,000 residents in our service area. It's an honor to take care of our community and to provide the right care at the right time. Last year, we cared for just over 6,500 inpatients in our facility, more than 100,000 patients in our clinics, and we provided nearly 300,000 outpatient testing, imaging, and ancillary services. We treated 31,000 patients in our emergency department. This strategy involves a carefully crafted, multi-pronged approach that enables us to assess the immediate and long-term needs of our patients and to put a system in place that allows us to have our practitioners be the best that they can be. It's not easy because we continue to struggle with increased complex care needs of our patients, changes in payment systems, and a workforce that seems to be shrinking and harder to hire. The metric of lag time provides a high-level comparison for patient appointments. And then we have patient satisfaction surveys that ask questions like, did you get the appointment as soon as you thought you needed it? And that gives us some insight into kind of a high-level comparison for patient appointments as well as our patient's perception. However, even combined, they don't give the full picture of, is this the right care at the right time? Prior to and in between those visits, there's a significant amount of care that's occurring. The goal is to create touch points for the patient so that when their scheduled visits occur, the patient has gotten the right care at the right time, the practitioner is performing to the top of their license, and the costs are controlled. However, even with all those touch points happening and that we're putting in place, we still need to have available provider appointments. That just has to happen. So with our greatest workforce challenge being provider at recruitment and retention, we struggle to provide enough of those appointments. Physician vacancies have a direct correlation with our access, it's true, and with our patient satisfaction. Recruitment has been a challenge due to the decline in available physicians wanting to coming out of their training, willing to work in rural areas that don't have that plethora of subspecialties, as well as minimal call requirements. In rural communities, they're on call more. Cardiology, OBGYN, infectious disease, ICU, and ENT are areas that we have struggled with recruitment due to those reasons. We have incorporated advanced practice providers, we've increased call stipends, contracted with third-party telehealth services, we've utilized locum agencies. Those have all been the things we've been doing to make sure our patients still have the right care at the right time. Daily, our physicians, advanced practice providers, nurses, and staff work with our patients to help them navigate through the system. We get the care in a timely manner, but it does take a lot of work and touch points. This continues to be a challenge at the system level, and we're going to continue to work hard to find solutions and take care of our community. Thank you for your time, and I'll turn it back to Judy.
So acknowledging the challenging position that RRMC faced, we appreciate the Green Mountain Care Board's support of our 2023 budget request. And we acknowledge that this request is far more significant than any other year. While our 2023 rates bolstered our financial position by providing necessary funding for inflationary costs, we knew as a leadership team that our financial stability would require actions greater than rates. And so this spring, the senior leadership team, in alignment with our board, initiated a cost reduction program that resulted in savings of $5.6 million, and we eliminated 45 positions. Again, our goal was not to impact access to care, but rather to focus on administrative overhead and efficiencies in patient care. Our reduction plan was an appropriate balance between clinical services and administrative overhead. The impact of the reduction drove our cost per adjusted discharge down by more than $275 a discharge, and will support improvement in RRMC's cost as we compare ourselves to other benchmarks as those benchmarks are updated. Together, the rate increase and our disciplined approach to cost containment provided a foundation to develop our 24 budget. To stabilize our financial position, RRMC used realistic assumptions that support utilization trends, inflationary factors, and cash flow needs. And it is important to note that most, if not all of these assumptions were supported by Green Mountain Care Board guidelines. The inflationary impacts facing healthcare have been profound. Jonathan Reynolds will provide information as to the inflationary impacts in our 24 budget, as well as to discuss the impact of diminished revenue capture opportunities within our 340B program.
Great.
JR.
Thanks, Judy. I'm Jonathan Reynolds again. Supply chain disruption coupled with high demand for supplies have driven costs up. Increased pharmaceutical costs, especially with many new drugs coming to market, demand inflationary funding that is excessive. The inflationary impact of pharmacy alone in our budget is driving more than $1.3 million. RRMC mitigates inflationary costs for both supplies and pharmacy medications by participating with Vizient in the Northeast Purchasing Coalition to secure discounts related to group purchasing programs. Through NPC alone, RRMC leverages cost savings in excess of $1.1 million each year. In addition to significant inflationary pressures, RRMC has been confronted with sharp declines in our 340B revenue. Our 2024 340B revenue budget has been reduced by $3.5 million, a result of drug manufacturers imposing contract pharmacy restrictions. 26 drug manufacturers have imposed restrictions thus far. As of June, we estimated our annual loss to be $6 million, while our budget only projected a loss of $3.5 million, proving to be an assumption that is already negatively impacting our performance. It's vital for our state legislators, state health departments, and hospital leaders to recognize that declines in 340B program will significantly impact all Vermont hospitals. Based on our 2023 projected operating performance, Vermont hospitals across the state would have an aggregate loss from operations of more than $5.6 million if not for the 340B program. This is in stark contrast to an operating gain with the 340B program intact of $59 million. 340B serves to subsidize underfunding in state and federal healthcare programs, and without 340B, Vermont hospitals will be at risk for financial sustainability. To continue our cost efficiency efforts and to offset these negative impacts to financial performance, RRMC has put in place a controlled hiring process that requires the review of every position, whether budgeted or not, to determine the need for funding. The process is not only a tool to manage costs, but also to stabilize our workforce. Regardless, RRMC continues to be challenged with staffing shortages, most notably in our nursing and direct patient care services like diagnostic imaging. I'll now transfer it over to Kelly Watson, our Chief Nursing Officer, who will provide an overview of these workforce challenges. Kelly?
Thank you, Jonathan. And thank you, members of the Green Mountain Care Board, for your time this afternoon. As Mark Foley mentioned in his opening remarks, our workforce is our most important resource. Judy shared that we have over 170 positions open or org-wide, with over 100 being nursing-related positions. Efforts on recruitment and retention to address critical staffing shortages are top priorities, as is lowering costs associated with managing those critical shortages. As Jonathan mentioned, ongoing assessments of resource needs are reviewed weekly, where we utilize benchmarking and productivity data to validate any staffing request. After we validate the need, we move quickly to fill vacancies to ensure access to care remains intact. Recruitment efforts have included grow our own programs, tuition reimbursement, sign-on bonuses, flexible working schedules, and developing meaningful partnerships with local academic institutions. Several of our employees, myself included, serve as faculty and clinical facilitators with Vermont State University's Vermont Tech and Castleton nursing programs. This allows opportunities to engage with students while also providing exposure to our organization. In collaboration with the Vermont AHEC, we engage with high school students interested in healthcare careers, which is another workforce pipeline we believe is worthy of our investment. While workforce recruitment is a top priority, equally as important is retention. Retention efforts include enhancing our recognition programs to ensure employees feel valued and appreciated for their dedication and hard work. Creating a safe work environment is another key element of retaining employees. We have heavily invested in creating a safer work environment by implementing new violence prevention tools, a new training program, increased security surveillance, and enhanced access controlled practices. We recently hired 30 new graduate nurses to join our team, and their success is critical to our success. We are in the process of reassessing our new grad residency program to ensure its value. This includes adding a mentorship component and utilizing new grad feedback to make program adjustments as needed. Other retention tactics include listening to our employees, working collaboratively with our nursing union, utilizing exit interview data to improve our performance, and developing leadership training programs for our current and future leaders. Investing in our workforce, implementing innovative staffing models to maximize resources, and partnering with academic institutions are key components of both recruitment and retention. Critical staffing shortages have pushed us to be more innovative than ever before to ensure effective utilization of resources while we have continued to provide high quality care to the communities we serve. At this time, I will return the presentation to Judy Fox.
So to conclude our introductory comments, I'd like to talk about our rate increase. So as you know, RRMC is seeking an increase of 5.6%. We understand that the impact of increases in our community, and we strive to limit the increase as much as we can. We have been responsible in both our request and have complied with the 8.6% trend factor that was established by the board's guidelines. It is important to note, however, that while our increase is 5.6%, commercial payers are only paying about half of that. The difference relates to contractual agreements or changes in payment rules that impact our reimbursement structure. I'd be happy to discuss this further, but ask that this would be considered privileged information, and we would be looking to talk with you about this outside of the public setting. We'd also like to convey our approach in supporting individuals who do not have insurance or who face high deductible plans. RRMC's financial assistance program allows full funding up to 300% of the federal poverty level and partial funding up to 500% of the federal poverty level. The result is that we budgeted, included in our 2024 budget, $7.3 million, which is equivalent to 40% of our entire self-pay reserve, which would include bad debt. RRMC agrees that the current system is not sustainable and that it is our shared responsibility to find collaborative, creative, and innovative ways to change the way healthcare is delivered and paid for. That said, we caution any decisions that attempt to impact the cost of care without a full understanding of the factors that drive our current challenges. Merely taking funding out of the system without changing care delivery, investing in supportive community programs that address mental health and substance misuse, or acknowledging the inequity in the current payment systems will not serve anyone well, particularly Vermonters who need a strong health system to be in place to care for them. Thank you.
All right, thank you. Those were substantive opening remarks. I think I took good notes. You presupposed some of the questions I was going to be asking today. So, you know, it's almost like you've been through this before. All right, so we're bringing up the tool here. And so board, I think it's important to note that this is one of 2 submissions that did fulfill the benchmark, which again is net patient revenue growth from fiscal year 22 actuals to the 24 budget of 8.6% or less, which was established in the fiscal year 23 guidance. So given that they met that very ambitious target, I think that's just something really important to keep in mind as we walk through this. They are the only PPS hospital that was able to fulfill that target. We heard from 2 others that were quite close, and they also of note the negative sign in the operating expense field. So that is largely what is helping make this budget comply with those requirements. You already spoke at length about how you're approaching labor and how you were thoughtful about the reduction in workforce. I'm curious, it sounds like, you know, best laid plans and all of that. How confident are you that operations will be smooth at this level of staffing, or do you have any concerns about having to replace some of these positions?
Do you want to talk from a nursing perspective?
Well, from the nursing perspective, we're being very mindful of staffing to our census to make sure that we're not just assuming that we need every single resource at every single moment. So this is working really closely with our leaders throughout various levels of nursing to ensure that we are monitoring that. But we do have, as Jonathan and I both mentioned, we are looking at our staffing needs every single week and really trying to be mindful to see, you know, we absolutely have to replace this person to keep this service intact. And so that's a ongoing, I don't even want to say weekly, it's a daily assessment to ensure that we're utilizing our resources the best we can.
Yeah, and it sounds like part of your assessment in addressing those resources has to do with productivity. How does that fit into the equation about hiring versus addressing it through productivity measures?
Do you? So we have a new benchmarking process that we subscribe to. We submit data on a pay period basis, and we then are allowed to get information back that tracks our productivity against like peers and cohorts. We use that information, that's part of our controlled hiring, and that helps to inform those decisions. As Kelly and Jonathan both said, controlled hiring is a process that you know, we meet every week. Discussions honestly happen every day.
So it sounds like a lot of information that you keep up to date. That makes a lot of sense. Any other questions from the board related to labor expenses specifically?
Just one quick follow-up. I'm just wondering what percentile you benchmark against when you're thinking about that productivity, the new data that you have.
Sure. So our goal is to get to 50, the 50th percentile. There are some departments that are already there. There are some departments that are a ways away. And so this goal is really needs to be addressed and managed at the department level with the long-term goal of getting everybody close to that 50th percentile.
Thank you.
Ms. Fox, what's the name of that tool?
It's called Premier.
And how long has Rutland been using it?
We have been using the productivity component of this system for about, I'm going to say 3 or 4 months. We used that in earnest when we began our cost reduction program in the spring of the year. It has 2 modules, a productivity module and a benchmarking module. Honestly, we're just beginning the benchmarking module. I can't sit here and tell you that we are proficient and mature in that, but certainly that is our goal as we move forward.
Thank you.
All right, advocate, any labor-related questions?
Yeah, thanks, Sam Push, healthcare advocate. I just want to commend Rutland and you, Judy, and your team for the coming in below the guidance and implementing the cost reduction plan. I think that obviously takes courage, commitment, and a lot of careful planning. So I was wondering if you could just at a high level speak to how you arrived at that decision rather than asking for an increase in commercial charge and or NPR, and what kind of obstacles you had to overcome in doing that.
Sure. So I will speak on behalf of Rutland Regional Medical Center. Every hospital in the state has a different set of challenges, and you'll hear from them. But we were really coming off from COVID. We had provided a number of services during COVID that we had to make decisions on as to whether those were important to move forward. And so it was really looking at how we were redefining our hospital and our services post-COVID. It starts with, at the top, our board is fully engaged and is working with us on strategic plans. And then it moves throughout our senior leadership team and our leadership on the ground. And so it takes everyone. The courage, we came off from a year where we had to ask for excessive rate increases. We knew that that was very difficult for our community. Having said that, there is high demand for our services. And so we were trying to strike that balance between access and cost.
Thank you.
Thank you very much. As far as utilization, let's get to you. Seeing that it was up quite high in fiscal year 22, I know that that's not a terribly representative year for utilization most places. So just curious how you, in a nutshell, tackled the puzzle of utilization in your budget.
Yes, sure. So speaking of 22, which serves as the base for this trend, our patients came back quick. And we were very busy as soon as restrictions were lifted. I think we were in the OR the next day. So we were ready to move forward and have really worked with our community in building kind of a safe environment for them to come back in. Having said that, there's an enormous amount of delayed care. And as our patients were coming back online, that has certainly been very evident, whether it's in our ED or in our inpatient units or in our clinics. If you look at our ED utilization, which is your bottom graph there, 17% of our patients are admitted from our ED. That's a little higher than the state average. I think the state average is around 13%. We are seeing patients who are sicker come through our emergency room. On average, we see about 85 patients a day, but that varies. It can go anywhere from 60 to 130. And so the transition in those patients really are challenging for our care teams. And as far as 23 and 24, we're staying the course. What you see for utilization is really what we're treating in patients today for patients, with the exception of a couple of areas. We use our wait times and our lag information to make decisions. And in that case, we saw that high-end imaging, particularly CT and MR, had very long lag times, not good for the patient, not good for our providers caring for that patient. So we've opened up hours, lengthened the hours in the day. The equipment is the equipment, but then also opened up weekend hours. We also have an expansion project underway for infusion, where we have seen a great demand in our community for infusion services.
Which is a good segue to the pharmaceutical expenses. I know oncology is a huge stressor for a lot of organizations. Just curious how you're kind of grappling with that, coupled with the 340B challenges.
Yeah, of course. So we're able to benchmark the medications that we use, especially in our cancer center and our non-cancer infusion settings. Visiting our GPO provides a drug pricing forecast that comes out twice a year that we can run our drug mix through. And you'll see that as a result of that, that's where the projected inflation of 4% came to be. I know that the benchmark nationwide was 2.3%, but the 4% is a highly specific number to Rutland Regional, and hence the rationale for that being in there. So it is based on true data and true utilization numbers. In terms of the volume, as Judy mentioned, we're just seeing increased requirements for medications that need to be infused. And for Vermonters, it's all about access. In rural areas, we support these patients that come to us and receive this care, as it's a bit different than other metro areas where there are more in-home services. So that is really a difference in this setting here.
Great. So I think, again, given that these factors and their sources were very well documented, and the submission came in within the benchmark, I don't have a ton of questions in the rest of the content areas. So I wonder if we want to cover any more from the board or the advocate before we go through the other cost exhibits.
I had one question. Sorry, Sarah. And I could hold this for later. I'm not sure when is best to ask it, but I'll ask it now. In the narrative on page 7, Judy, you talked about the Medicaid fixed payment change. And I'm wondering if you have any information about what's driving that.
Are you talking about the $600,000 budgeted loss? Sure.
Yes.
Yeah, so that number is quite volatile. And so that is the difference between what we get in fixed payments from OneCare and what we call shadow payments, what we would have received had we not been in a OneCare fixed payment program. And at the time we were putting our budget together for the months of March, April, and May, we were behind by about $250,000. And so this kind of ekes and flows in terms of patient demand. But as we see the increase in costs, we don't expect that this is going to get much better. And so that is really a result of looking at our fixed payment against both our adjudicated claims and those claims that we consider lag and waiting to be processed.
Thank you.
I have one question I'd like to propose. First of all, I just want to say thank you so much for the very well written, concise, but detailed budget submission, incredibly helpful. And one thing I really wanted to highlight in this, which has been, I think, a really great addition to the discussion on custodial care patients is your analysis on page 16, which is really very helpful to understand the problems, the challenges, and the financial impact that you're experiencing from these various challenges with discharges and ED boarding. And so I thought this was a really helpful and clear description of that problem. So thank you. My question relates to this, which is actually, what are other challenges that you have found with throughput of inpatients, challenges with length of stay, other than custodial patients discharging to skilled nursing facilities and whatnot? Are there other challenges that you've been able to identify and understand the impact of them, and any mitigation strategies?
Sure. So before I answer that question, I do want to give a shout out to Springfield Hospital. So with our custodial patients, our care team has gotten together with Springfield Hospital's care team, looking at ways in which we can provide care for these patients at a better location and with a better reimbursement structure. We're very early in on this process, have only transferred one patient, but it's really important as we think about how Vermont hospitals work together. And in this particular case, these custodial patients, really important. And that happens to be our Medicare patients actually awaiting placement. So there's that piece. I would tell you that when we look at our utilization is less, other than the custodial, it's less about who's getting in and more about how long they're staying. And so if you look at our utilization statistics over the last 4 years, in total, we had less than 150 days denied for inpatients because of a utilization denial. Where we are seeing what we call avoidable days is where a patient has come to us for acute need, but we can't get them out of the system. And that's not just custodial, it's altogether different. So we could be holding a psychiatric patient in our ED, and the state has provided some reimbursement for some of those patients, but not all. We have same-day surgeries where we have a surgery that is predicted to be outpatient, but for whatever reason, the needs of that patient, they have to stay. We call it same-day surgery extend. They may spend the night with us unplanned. We have observation patients. On average, we have about 3 observation patients a day. Most of these observation patients are medical patients. Most of them relate to cardiac and rule outs. But those are all areas in which we have what I would consider patients in inpatient beds that may not be fully acute. I don't know if that's helpful or not.
I think so. I guess I was trying to get at is, are there patients that you have in inpatient beds? Do you have a process of trying to identify those that could be managed more expeditiously, and if you found from that process anything that you could find benefit to intervening on?
Yeah, great question. So last month, we had 2 patients undergo surgical procedures. Those patients, one was a general surgery patient, another was an orthopedic patient. Both of those patients did very, very well. We discharged them the same day. We then received a denial from the insurance company, in this case it was Medicare, because those procedures are only paid on an inpatient basis. So although we did everything right, we didn't receive any reimbursement. So my point in sharing this with you is it's complicated. And we really have to really lean on our utilization department. We have to lean on our physician leaders to help us make some of those really skilled decisions. The other piece is with Medicare Advantage. We have patients who we hold in our facility longer than we need to because they're in a Medicare Advantage plan, and we have to wait for a prior authorization to get them to their next stage of care. That can hold up care 2 to 3 days, depending on the situation.
Thank you. That's an area we've been hearing about frequently this last 2 weeks.
Hi, Judy. May I just a quick follow-up question to this whole conversation around, uncompensated care. We heard from another hospital that there's a new long-term care facility opening up. There's going to be increased capacity. My understanding is 60 new beds. Will this help in your mind in the Rutland area? And how might it impact your assumptions about length of stay and utilization?
So I hope so. I hope it helps. The largest impediment of custodial patients and moving patients on our lack of bed for either a payment source or for a perceived behavioral issue. And so depending on what this long-term care facility criteria is, we would really be looking to partner with them. Having said that, I'm not sure when this facility is supposed to come online. I'm not sure that it will be too impactful in the near future. More of a long-term planning tool.
Great. Okay. Thank you.
Any other board questions or advocate questions?
Hi, so this is Charles Becker. I'm a staff attorney with the Healthcare Advocates Office. I suppose I should have waited for the board to make sure that there were no more board questions before I jumped in. Were there no more? Okay, all right. So it was unclear to me too where my question might fit in. So it relates to 340B. So I thought I'd jump in now. So thank you. So you noted earlier that there are 340B revenue declines stemming from manufacturer restrictions on contract pharmacies, and I read that in your narrative, and that got me to thinking that, well, you also have an in-house pharmacy, and that led me to wonder even more. So what is RRMC doing to help uninsured and underinsured patients with high pharmacy costs? Because you serve a community with a lot of lower income folks, and I imagine a lot of people get great care from one of your specialist physicians, but then they get prescribed the medication they can't afford, and so they don't adhere to the treatment. And I'm looking over your website, it doesn't look like RRMC offers any financial assistance through its in-house pharmacy. And so my question is, has RRMC ever considered passing through some of its 340B savings to uninsured or underinsured patients by implementing a prescription drug financial assistance program through its in-house pharmacy?
So I will say indirectly, not directly. If you look at our financial assistance program, we provide full financial assistance up to 300% of our federal poverty level. We also provide a tiered financial assistance up to 500% of the federal poverty level, which I believe is the highest in the state. And so we use our financial assistance program to work with those patients that are most vulnerable. If a patient is receiving pharmaceuticals as an outpatient, those pharmaceuticals would be part of our financial assistance program, and they would be eligible for reimbursement or assistance.
Thank you for that. And maybe following these hearings, if you would be open to it. I mean, I was reviewing your website just today, and it is not at all clear. In fact, it says that pharmacy costs are excluded from your financial assistance policy. So maybe we could work together to make that a little bit more clear to folks.
Absolutely.
Thank you.
And to jump off, Charlie, just a kind of more broad question. From reading your community health needs assessment and just being a little bit familiar with the work of the Bowes Health Trust, it's pretty clear that Rutland is committed to health equity. And I was wondering how your team evaluates making progress towards specific, goals that you set or specific race equity metrics over time.
Yeah, so the first step is measuring and putting together a measurement system that allows us to understand where baseline is and where we're headed. We have a team in place that is working through that process. That team is working in partnership with our Diversity, Equity, and Inclusion Committee to support the work of the committee. The Bowes Health Trust took a fairly inflexible stance, if you will, to begin our process, that we would not entertain the funding of any community project if they could not validate and confirm for us their stance in DEI and how their funding, our funding, would impact those vulnerable communities.
Thank you.
Sarah, I think the
All
whole
right.
HCA team is keying in here, so I've got one more.
Okay.
Or actually, I'm the last member of the HCA team to ask a question. Good afternoon, Mike Fisher, healthcare advocate. I wanted to spend a moment talking with you all about bad debt and free care, and I'll start with a recognition of your hospital over time, over the last number of years, has, I think, been in the lead or close to it with regard to that relationship between bad debt and free care. And yes, Judy, I think you're right. You also lead in the generosity of the 500% for partial payment. So I wanted to recognize that. 2022 was a bit worse, but over time, you've been doing a great job. I wanted to just spend a moment asking to understand a little bit of these numbers. I have to admit, board and public, I have a little concern that my focus on the relationship